Hi, welcome to our channel of IGNOU Audiobooks. Indira Gandhi National Open University, School of Continuing Education, Bachelor's Degree Program, Elective Course, Rural Development, BRDE-101 Rural Development, Indian Context, BLOCK6, Emerging Rural Society, Unit 3 Rural Healthcare. 3.0 Aims and Objectives. After learning of this unit, you should be able to describe the status of healthcare in India, explain the rural infrastructure of healthcare system, explain National Rural Health Mission, and explain various programs for healthcare. 3.1 Introduction. Health is not just absence of diseases, it is a state of mental, physical and social well-being. Healthcare system is a new umbrella which covers screening, diagnosis, treatment, prevention, health education and awareness. Healthcare is broadly divided into two sectors, government sector and private sector. In urban areas one can locate government hospitals and well-equipped private hospitals. When we look towards rural India, we can see lack of resource, both human and physical infrastructural. However, government system rural area is organized and linked with the district hospitals. Middle dot. When we try to portray rural healthcare, we can see that there are striking regional inequalities. Population stabilization is still a challenge, especially in states with weak demographic indicators. Only 10% Indians have some form of health insurance, mostly inadequate. Hospitalized Indians spend on an average 58% of their total annual expenditure. Over 40% of hospitalized Indians borrow heavily or sell assets so cover expenses. Over 25% of hospitalized Indians fall below poverty line because of hospital expenses. 3.2 Infrastructure for rural health care. The healthcare infrastructure in rural areas has been developed as a three-tier system. Subcenters, primary health centers, community health centers. 3.2.1 Subcenters. The subcenter is the first contact point between the primary healthcare system and the community. In middle dot each subcenter at least one auxiliary nurse midwife, A&M female health worker and one male health worker are employed. TI1R is a provision for one additional second A&M on contract basis under NRHM. Subcenters are assigned tasks relating to interpersonal communication in order to bring about behavioral change and provide services in relation to maternal child health, family welfare, nutrition, immunization, diarrhea control and control of communicable diseases programs. The subcenters are provided with basic drugs for minor ailments needed for taking care of essential health needs of men, women, and children. There are 1,47,069 subcenters functioning in the country as on March 2010. Look at the screen for table content. 3.2.2 Primary Health Centers, PHCs. PHC is the first contact point between village community and the medical officer. The PHCs were envisaged to provide an integrated curative and preventive health care to the rural population with emphasis on preventive and promotive aspects of health care. The PHCs are established and maintained by the state governments under the Minimum Needs Program, MNP, Basic Minimum Services, BMS, program. As per minimum requirement, a PHC is to be manned by a medical officer supported by 1.4 paramedical and other staff. Under NRHM, there is a provision for 2 additional staff nurses at PHCs on contract basis. It acts as a referral unit for 6 subcenters. It has 4 to 6 beds for patients. The activities of PHC involve curative, preventive, promotive family welfare services. There are 23,673 PHCs functioning as on March 2010 in the country. 3.2.3 Community Health C_enters, SICHCs. SICHCs are being established and maintained by the state government under MNP/BMS program. As per minimum norms, A SOCE is required to be manned by 4 medical specialists, i.e. surgeon, physician, gynecologist and pediatrician, supported by 21 paramedical and other staff. It has 30 indoor beds with 1 OT, X-ray, labor room and laboratory facilities. It serves as a referral center for 4 PHCs and also provides facilities for obstetric care and specialist consultations. As on March 2010, there are 4,535 SOCEs functioning in the country. Look at the screen for table content. Population norms. Subcenters, PHC and SOCEs are set up as per the following population norms. Look at the screen for table content. 3.3 National Rural Health Mission. In 2005, Ministry of Health and Family Welfare Government of India approved the launch of the National Rural Health Mission 2005-12 for providing integrated comprehensive primary healthcare services, especially to the poor and vulnerable sections of the society by a resolution. The mission aims to undertake architectural correction of the health system to enable it to effectively handle the increased middle allocation for public health. It also aims to bridge gaps in rural healthcare through increased community ownership, decentralization of the programs to the district level, intersectoral convergence and improved primary health care. The mission aims to achieve the goal of the National Population Policy and the National Health Policy through improved access to affordable, accountable and reliable primary health services. 3.3.1 Accredited Social Health Activists. ASHA, a female accredited social health activist, ASHA, works in every village large habitat as the interface between the community and the public health system. ASHA acts as a bridge between the A&M and the village and be accountable to the panchayat. She is an honorary volunteer, receiving performance-based compensation for promoting universal immunization 1 referral and SO1T services for RCH, construction of household toilets, and other healthcare delivery programs. She is trained on pedagogy of public health. They were underscoped and mentored through a standing mentoring group at national level, incorporating best practices and implemented through active involvement of community health resource organizations. She facilitates preparation and implementation of the village health plan along with Anganwadi worker, A&M, functionaries of other departments, and self-help group members, under the leadership of the Vaihage Health Committee of the Panchayat. She is given a drug kit containing generic Ayush and allopathic formulations for common ailments. 3.3.2 Strengthening Subcent_RS, PHCs and SOCEs. Subcenters are strengthened by supply of essential drugs, both allopathic and Ayush, to the subcenters. In case middle of additional outlays, multi-purpose middle workers, male, additional A&Ms wherever needed, sanction of new subcenters as per 2001 population norm, and upgrading existing subcenters, including buildings for subcenters functioning in rented premises, will be considered. Mission aims at strengthening PHC for quality preventive, promotive, curative, supervisory and outreach services, through adequate and regular supply of essential quality drugs and equipment, including supply of auto-disabled S for immunization to PHCs, provision of 24-hour service in 50% PHCs by addressing shortage of doctors, especially in high-focus states, through mainstreaming Ayushman power. Observance of stand treatment guidelines and protocols, in case of additional outlays. Intensification of ongoing communicable disease control programs, new programs for control of no communicable diseases, upgradation of 100% PHCs for 24 hours referral service, and provision of second doctor at PHC level, 1 male, 1 female. SOCEs were strengthened by a key strategy of the mission, that is operationalizing 3,222 existing community health centers, 30 to 50 beds as 24-hour first referral units, including posting of anesthetists. Codification of new Indian public health standards, setting norms for infrastructure, staff, equipment, management etc. for SOCEs, promotion of stakeholder committees, Rogi Kalyan Samitis, for hospital management, developing standards of services and costs in hospital care, develop, display and ensure compliance to Citizens Charter at SOCE/PHC level. In case of additional outlays, creation of new community health centers, 30 to 50 beds, to meet the population norm as per Census 2001, and bearing their recurring costs for the mission period could be considered.
You are listening to this audiobook on Audio Learn IGNOU. 3.3.3 District Health Plan. District Health Plan is an amalgamation of field responses through village health plans, state and national priorities for health, water supply, sanitation, and nutrition. Health plans would form the core unit of action proposed in areas like water supply, sanitation, hygiene and nutrition. Implementing departments would integrate into district health mission for monitoring. District becomes core unit of planning, budgeting and implementation. Centrality sponsored schemes could be rationalized/modified accordingly in consultation with states. Concept of funneling funds to district for effective integration of programs. All vertical health and family welfare programs at district and state level merge into one common district health mission at a district level and the state health mission at the state level. Provision of project management unit for all districts, through contractual engagement of MBA, inter-charter/inter-cost and data entry operator, for improved program management. 3.3.4 Converging sanitation and hygiene under NRHM. Components of Total Sanitation Campaign TSC include DIEC activities, rural sanitary marts, individual middle household toilets, women's sanitary complex, and school sanitation program. Similar to the DHM, the TSC is also implemented through Panchayati Raj institutions, PRE. The District Health Mission, therefore, guides activities of sanitation at district level, and promotes joint IEC for public health, sanitation and hygiene, through Village Health and Seromutation Committee, and promotes household toilets and school sanitation program. ASHA is given incentive for promoting household toilets by the mission. 3.3.5 Strengthening Disease Control Program. National Disease Control Programs for Malaria, TB, Kala Azar, Malaria, blindness and iodine deficiency and integrated disease surveillance program are being integrated under the mission for improved program delivery. New initiatives were launched for control of non-communicable diseases. The CNE surveillance system at village level was strengthened. Generic drugs, both Ayush and allopathic, for common ailments at village, SC, PHC/SITC level are supplied. 3.6 Role of Panchayati Raj institutions. Panchayati Raj institutions are being involved in National Rural Health Mission from village level to district panchayat level in various functions. The Village Health Committee of the Panchayat is involved in the preparation of the village health plan, and to promote intersectoral integration. PRE are involved in Rogi Kalyan Samitis for good hospital management. Training is provided to the members of PRE. Health-related databases is made available to all stakeholders, including panchayats at all levels. 3.3. 7 Focus on northeastern states under NRHM. All 8 northeast states, including Assam, Arunachal Pradesh, Manipur, Meghalaya, Mizoram, Nagaland, Sikkim, and Tripura, are among the states selected under the mission. For special focus. States are supported for creation/upgradation of health infrastructure, increased mobility, contractual engagement, and technical support under the mission. Regional Resource Center is being supported under NRHM for the northeastern states. Funding is made available to address local health issues in a comprehensive manner, through state-specific schemes and initiatives. 3.3.8 Involvement of NGOs in the mission. NGOs are involved in healthcare in various activities. They are engaged in mentoring. Group for ASHA, training, behavior change communication and technical support for ASHA/DHM health resource organizations, service delivery for identified population groups on select themes, monitoring, evaluation and social audit. 3.3.9 Mainstreaming Ayush. The mission seeks to revitalize local health traditions and mainstream Ayurveda, yoga, and naturopathy, Unani, Siddha and homeopathy, Ayush, infrastructure, including manpower, and drugs, to strengthen the public health system at all levels. Ayush medications are included in the drug kit provided at village levels to ASHA. The additional supply of generic drugs for common ailments at subcenter/middle.phc/SIHC levels under the mission includes Ayush formulations. At the SIHC level, 2 rooms are provided for Ayush practitioners and pharmacists under the Indian Public Health System (IPHS) model. Single doctor PHCs way middle.he upgraded to 2 doctors PHCs by mainstreaming Ayush practitioner at that level. 3.4 Healthcare Programs/Schemes. 3.4.1 The National Vector-Borne Disease Control Program. The National Vector-Borne Disease Control Program is a comprehensive program for prevention and control of vector-borne diseases, namely malaria, filariae, Lassa, Japanese encephalitis, dengue and chikungunya, which is covered under the overall umbrella of NRHM. 3.4.2 The National Leprosy Control Program. The National Leprosy Control Program was launched by the Government of India in 1955. Multi-drug therapy came into wide use from 1982 and the National Leprosy Eradication Program was introduced in 1983. Since then, remarkable progress has been achieved in reducing the disease burden. India achieved the goal of elimination of leprosy as a public health problem, defined as less than 1 case per 10,000 populations, at the national level in the month of December 2005 as set by the National Health Policy, 2002. 3.4.3 National Iodine Deficiency Disorders Control Program, NIDCP. Iodine, an essential micronutrient required RE1Y at 100 to 150 micrograms for normal human growth and development. Deficiency of iodine can cause physical and mental retardation, cretinism, abortions, stillbirth, deaf mutism, squint and various types of goiter. The objectives of the program is to a. Survey to assess the magnitude of the iodine deficiency disorders, b. Supply of iodated salt in place of common salt, c. Survey to assess iodine deficiency disorders and impact of iodated salt after every 5 years, d. Health education and publicity, information, education, and communication, IEC, e. Laboratory monitoring of iodated salt and urinary iodine excretion. 3.4.4 Institutional deliveries. Janani Suraksha Yojana was launched in 2005 with an objective to increase institutional deliveries. Under the scheme, the government provides a cash incentive for pregnant mothers to have institutional births as well as pre- and antenatal care. As a result, significant increase in institutional deliveries is reported by the states. With the Janani Suraksha Yojana and other schemes of state government are motivating rural population for institutional delivery. Benefits of institutional deliveries are being imparted by the ASHA, ANMs and other stakeholders. Some incentives are given to the pregnant woman !D to delivered child also. 3.4.5 Family Planning and Reproductive Child Health. In 1952, India launched T&D, world's first national program emphasizing family planning to the extent necessary for reducing birth rates to stabilize the population at a level consistent with the requirement of national economy. Since then, the family planning program has evolved and the program is currently being repositioned to not only achieve population stabilization but also to promote reproductive health and reduce maternal, infant and child mortality and morbidity. To promote maternal health, pregnant women are frequently visited by the health workers. Vaccination and vitamins are provided as per the schedule. Short-term and long-term options are available for the family planning. Contraceptives like pills and condoms are made available at SC/PHCs/CHCs. The National Family Welfare Program initiated the social marketing program of condoms in 1968 and that of oral pills in 1987. Under the social marketing program, both condoms and oral pills are made available to the people at highly subsidized rates, through diverse outlets. The extent of subsidy ranges from 70% to 85% depending upon the procurement price in a given year. Both male and female are motivated for the sterilization as permanent mode for family plan. 3.4.6 Revised National TB Control Program, RNTPC, National TB Program, NTP, was started in 1962. Program reviews showed that only 30% of estimated tuberculosis patients were diagnosed and only 30% of those were treated successfully. Based on the findings and recommendations of the review in 1992, the GO evolved a revised strategy and launched the Revised National TB Control Program, RNTCP, in the curriculum. It incorporates the principles of directly observed treatment, short course, DOTS, the Global TB Control Strategy of the World Health Organization. The program provides, free of cost, quality anti-tubercular drugs across the country through the numerous primary health centers, PHCs. The 5 principal components of DOTS are: political and administrative commitment, K6 detection by sputum smear microscopy, uninterrupted supply of good quality anti-TB drugs, standardized treatment regimens with directly observed treatment for at least the first 2 months. Middle dot. Systematic monitoring and accountability. 3.4. 7 Indira Gandhi Matritwa Sahayog Yojana, IMSI. This is a new scheme introduced in 2010 by the Ministry of Women and Child Development for pregnant and lactating P&L women, keeping in view the need for giving maternity benefits to them so as to compensate partly for their wage loss and at the same time for fulfillment of conditions essential for ensuring safe delivery and promotion of infant and young child feeding practices. Thus, the payments under THC_scheme will be conditional. The scheme is being implemented from 2010-11 in 52 pilot districts across the country. To begin with, scheme is using the ICDS platform and will cover approximately 14 lakh women in the initial years. IMSI is a centrally sponsored scheme under which amount will be given as grant in aid to state governments/union territories. An amount of 101 crore has been released for IMSI up to 28 February 2011. A cash incentive of 4,000 is to be provided under the scheme to P&L women of 19 years of age and above, for the first 2 live births, subject to the woman fulfilling specific conditions relating to maternal child health and nutrition. All government/PSUs, central and state, employees would be excluded from the scheme as they are entitled for paid maternity leave. Cash incentive would be provided in 3 installments, between the second trimesters of pregnancy till the infant completes 6 months of age as under. Look at the screen for table content. Cash transfer 1,500 rupees, at the end of second trimester. Conditions. I. Registration of pregnancy within 4 months. 2. 1 antenatal checkup, minimum, including IFA and TT. 3. Attending counseling session, minimum 1 incentive under JSY, at the time of birth of MOHA and FW, condition for institutional/home delivery as per norms. 1,500 rupees. 3 months after delivery, conditions. I. Childbirth registration. 2. Immunization. 3. Attending growth monitoring and counseling sessions. 1,000 rupees, 6 months after delivery, conditions. I. Exclusive breastfeeding for 6 months and introduction of complementary feeding, self-certification by mother and immunization. 3. Attending growth monitoring and counseling sessions. 3.4.8 Blindness Control Program. National Program for Control of Blindness was launched in the year 1976. Cataract surgery, school eye screening and cornea transplants are the focused activity of the program. Eye banks are being supported under this PRO-E to reduce blindness. Cornea transplant is available at GMT, hospitals and voluntary organizations. 3.4.9 Disability Rehabilitation. Survey, screening and assessment of persons with disabilities are conducted with the Help Social Justice Department in collaboration with District Medical Board. Caliper, crutches, tricycle, wheelchairs, hearing aid and other aids and appliances are provided to the children/persons with disabilities. Corrective surgeries are conducted for persons with physical disabilities. The 3rd of April 2010 HIV/AIDS control. Through information education and communication, IEC, activities awareness is created regarding HIV/AIDS. Rural population is made aware about route of transmission. Targeted intervention projects are being run for high-risk groups like commercial sex worker, truckers, migrant labour and intravenous drug abusers. ASHA and ANMs are being trained in pre-test and post-test counseling related to HIV/AIDS issues. Condom promotion program is promoted to reduce risk in sexual behavior. Sexually transmitted diseases increase vulnerability to HIV. To prevent HIV transmission, STD are being treated. Parivar Swasthya Melas are organized for the treatment of STD and awareness. Testing of HIV status can be done by a simple blood test. ART medication is available for the persons living with HIV/AIDS. The 3rd of April 2011 National Immunization Program. Immunizati_O for the pregnant women, infants and children is done at each sub-centers, primary health centers and community health centers as per the National Immunization Schedule, NIS. Look at the screen for table content. The 3rd of April 2012 Rogi Kalyan Samiti. Rogi Kalyan Samitis are formed with expectations to make functioning of the hospitals more accountable, transparent and ND-based. More than 8,000 Rogi Kalyan Samitis/hospital development committees have been set up in the country. Nearly all district/sub-district hospitals and SOCEs have opened their own bank accounts. PHCs are also in the process of doing so. 5 rupees lakhs has been provided for district hospital RKSs and rupees 1 lakh for sub-district/SOCE/PHC hospitals/centers. The 3rd of April 2013 National Mental Health Program. With physical health, people are being aware regarding mental health. The Government of India has launched the National Mental Health Program, NMHP, in 1982. Program is integrated with primary health systems. 3.5 Let us sum up. In this unit, efforts have been to analyze the situation related to healthcare in India. It provides detailed information about healthcare infrastructure and programs and initiatives to improve healthcare facilities in rural areas. 3.6 Keywords. ASHA, accredited social health activists. PHC, primary health. SOCE, Center Community Health Center. NRHM, National Rural Health Mission.
Thank you for watching. We will see you in the next video with the next chapter.